Hello, everyone, and welcome to a new CPH 290 lecture. Today, it's a great pleasure to have Serina Chang. So Serina is an incoming assistant professor at UC Berkeley and with a joint appointment at CPH as well. She recently completed her PhD in CS at Stanford University, and she's currently a postdoc at Microsoft Research in New York. Serina's research develops AI and graph methods to study human behavior, improve public health, and guide data-driven policymaking. And her work is recognized by KDD Best Paper Award, NSF Graduate Student Fellowship, Meta PhD Fellowship, Stanford Finch Family Fellowship, EECS Rising Stars in Data Science, and Cornell Future Faculty Symposium. And her work on COVID-19 modeling of vaccine deployment using mobility data, it's a very popular work that has been covered by over 650 news outlets, including the New York Times and the Washington Post. So thank you so much, Serena, for joining us today, and I will hand it over to you.
Thanks so much, Ahmed, and thank you all for being here. I'm excited to be here. And today I'm going to be presenting about inferring and simulating human behaviors for public health. So to begin, and you probably know this, human behaviors are really crucial to understand for public health decision-making. But the challenge is that they're often difficult to observe. For example, when we talk about pandemics, pandemics are driven by infectious diseases, and they are spreading over contact networks. Contact networks are basically networks that define who is in contact with whom. Maybe you passed each other at the same bus stop, or you sat at the same restaurant. And when we form these networks, we can then model the spread of COVID or other infectious diseases as spreading over those contact networks. And so understanding patterns of contact, this sort of behavior, is really essential to understanding how do we control pandemics and limit the spread of infection. Other behaviors include masking, as well as vaccinations. All of these behaviors are choices people are making that then guide the trajectory of the pandemic and the epidemic. There's a lot of challenges in observing behaviors. Let me go over a couple first. So the first thing is that behaviors are really heterogeneous. And what I mean by that is different subpopulations or even different individuals are doing different things. So coming back to the pandemic example, when we look at something like social distancing, our work has shown differential social distancing rates across different groups, depending on things like socioeconomic status or political affiliation. And so this makes observing behavior harder because you can't just observe it in aggregate. You have to be able to slice up your data finely enough so that you can capture these heterogeneous behaviors. Another challenge is these rapid changes over time. So for example, during the pandemic, we saw a huge drop in contact patterns and in mobility patterns early in the pandemic when all of the social distancing started kicking in. And so what this means for observation is that it's not enough to just observe behaviors once every year or something, or sometimes even once every month. In order to capture these rapid behaviors, you also need frequent signals that allow you to capture these rapid changes over time. And so how do we usually get behavioral data? Well, a very common method is to do surveys. And so you actually just survey people on what are your behaviors. For example, have you been vaccinated or do you intend to get vaccinated? But surveys come with a lot of costs, both financial costs as well as the costs to recruit participants and to run the survey. And so these costs can often be prohibitive, meaning that you can't capture a large enough population to get the heterogeneous behaviors, or you can't run your survey frequently enough to get these rapid changes over time. And then finally, some other issues are, even if you did have the surveys that you could ask, maybe you would end up having self-reporting bias. So certain behaviors are quite sensitive, like maybe vaccination or what news you're reading, and people might not be as forthcoming about their actual behaviors, even if you could ask them the question. Even if you do have the data, sometimes there are privacy constraints where you wouldn't want to release that data publicly, especially in public health contexts. There are behaviors, for example, sexually transmitted diseases and the networks over which those diseases can be transmitted. Those kinds of behaviors and networks you might not want to release publicly. And then finally, one reason why behaviors might be tough to observe is because they literally haven't happened. And so here I'm talking about future or counterfactual behaviors. Future means, just in the future, we don't know how many people are going to get vaccinated. We don't know what the contact patterns are going to be. But counterfactual behaviors is saying, what if the world had been slightly different? What if we had lockdown at this time? What if we had reopened restaurants at this time? And again, that's not observed because we can't see these parallel worlds and observe the behaviors that would have happened. So for all of these reasons and more, behaviors can be quite challenging to observe. So the approach of my work is to develop machine learning methods to close these gaps in observation. And in particular, I take two approaches. The first one is to try to infer these behaviors from novel data sources. And so this is complementary to more traditional methods like surveys, but we can use novel data sources to infer those behaviors, and I'll define what I mean by novel data source. The second approach, which is in more of my recent work, is to take advantage of these LLMs and their unprecedented capabilities and to try to actually simulate these behaviors using the fact that they've ingested a ton of pre-training data and know some things about how humans might behave under different conditions. So specifically, this first approach is using novel data sources. Those are data sources like geolocation from cell phones or wearables or social media. And there's a lot of advantages to this kind of data. For example, it tends to capture very large populations. A lot of people have cell phones, for example, and that means with that level of penetration into the population, you can then slice your data quite fine so that you can capture these heterogeneous behaviors. Another advantage is that a lot of the signals from these data sources are passive and frequent. And so that means you're able to get rapid changes over time, and you can collect the data without much additional cost. And finally, because it's passive, it's recording your actual behavior in the wild, as opposed to asking you to report your behavior. And so that can get around some of these self-reporting biases. But this approach doesn't capture all of the challenges. And so in particular, in my recent work, I've been looking at simulation as a way to address three particular challenges. One of them is costs, again. So simulations are a good way to create synthetic responses without having the costs of having to ask real participants, or maybe in addition to asking real participants. Also, they can address privacy concerns. And so now you're able to generate realistic data that looks like real individuals, but doesn't actually give away information on real individuals. And then finally, a really nice thing about simulations is that you can capture future or counterfactual behaviors by simulating what-if scenarios with these LLMs. And finally, I'm not just interested in behaviors themselves, but thinking about behaviors in the context of these public health decisions that we started off with. And so this usually takes some three-step process where you have the estimated behaviors, either through inference or through simulation. And then you plug that into some sort of model where you can model some public health relevant decisions or outcomes out of that. So for example, maybe you model the spread of COVID over some estimated contact network. And when you're doing this modeling, you now have a chance to get at competing objectives that often appear in difficult high-stakes decision-makings, like in public health. For example, if you want to balance reopening the economy versus minimizing predicted infections, these sort of models over behaviors allow you to look at competing objectives. And finally, we take these models to derive new public health insights, for example, around reopening plans or reducing disparities or distributing vaccines. So for today, I'm going to try to get through these two different main approaches, the first one being inferring behaviors from novel data sources, and the second one being simulating behaviors with LLMs. And to begin, I'm going to talk about inferring mobility networks from location data. So that's going to be our first novel data source, and then modeling the spread of COVID over that network. And this is joint work with many great collaborators. It was co-led with Emma Pearson and Peng-Wei Ko, and was published in Nature in 2021. So to begin, like I mentioned earlier, this contact network is really crucial for understanding how to respond to the pandemic. For example, questions like, how do we reopen safely? It depends on who is coming into contact where. And then how do we reduce disparities? It depends on different risks that contact is bringing to different communities. So understanding this contact network is crucial. But we don't usually know the true contact network because we don't track who is coming into contact with whom. So if we don't know the true contact network, what can we do instead? And prior work has explored a number of alternatives. For example, maybe you make some assumptions. You assume that people mix uniformly within, for example, cities. Or maybe you use the data that you do have, which is at a coarser granularity, like airline data. But the issue with these two approaches is that you're going to miss this heterogeneity that we talked about earlier, you're going to miss the heterogeneity at local levels. So it's not, in fact, true that people mix uniformly within cities. And with these assumptions or coarser data, you'll miss that local heterogeneity. On the other hand, something else you could do is come up with an epidemiological model that has a lot of parameters. So maybe one parameter for every neighborhood to make up for missing the actual contact network. But the issue with this approach is now you have a model with a lot of parameters and not a lot of data to fit it to. So in epidemiology, we often only have aggregated daily cases at best. And so now you're trying to fit this over parameterized model, and you can run into issues with overfitting or challenges with parameter identifiability. So our solution instead is to infer fine-grained mobility networks directly from aggregated location data. And our basic premise is this: if you can successfully infer these complex fine-grained networks that really encode the real behaviors of people during this time, then your epidemiological model can actually be very simple. And the basic idea is that the networks, through their complexity, will absorb much of the complexity of disease spread so that your model can still be simple, but you can still model the spread of COVID accurately. And specifically, this is the network inference problem we're trying to solve. So we want the hourly visits of people to places, and we want the hourly visits so that we can model the spread of COVID based on who is visiting where at the same time. But the challenge is that data that is released tends to be more aggregated and not networked. And so, for example, the data we use in this work is from SafeGraph, and SafeGraph aggregates data to the level of census block groups, which are basically neighborhoods of 600 to 3,000 people. I'm going to refer to these as CBGs. And SafeGraph also aggregates data to the level of points of interest, or POIs. And these are individual public locations like restaurants, grocery stores, gas stations, etc. And SafeGraph has individual GPS pings, but they aggregate and assign them to CBGs and POIs in order to protect privacy. And so our goal is to keep the data aggregated, but we want to reconcile the data that they give us so that we can infer the full network of visits. So specifically, we want to infer this bipartite network that says in every hour, how many people from this CBG visited that POI. We want to do that for every pair. So how are we going to do this? So more specifically, SafeGraph provides, first of all, the hourly visitors to each POI, and they also provide the hourly visitors from each CBG. And so this provides hourly data, but it doesn't give us a network that we want. On the other hand, SafeGraph also provides monthly estimates of each POI's home CBGs. And so that does give us a network. It tells us how the CBG to POI network aggregated at a monthly level, though, not at the hourly level. And so the question then is, how do we reconcile these two pieces of information? And what I'm going to show you is how you can use an old algorithm called iterative proportional fitting and repurpose it for this purpose. So you can now reconcile it to reconcile these two data sources so you can infer hourly CBG POI networks. So to take a step back, iterative proportional fitting, or IPF, is this classic statistical algorithm. You might know it by other names like Sinkhorn's algorithm, biproportional fitting, and so on. The way that it works is first it takes in an initial matrix X, and then you have target marginals P and Q. So the row marginals P, that's what you want your rows to sum up to, and then column marginals Q, that's what you want your columns to sum up to. And then you want to do what's to solve the matrix balancing problem. And that's saying learn diagonal matrices D0 and D1 such that D0 x D1, so when you scale X by D0 and D1, you're now able to fit both the row marginals and the column marginals. And the way that iterative proportional fitting, or IPF, does this is that it iteratively scales the rows and then the columns. So what it does is on the even iteration, you're going to scale the rows to match the row marginals. So you take D0 and you adjust it so that P is satisfied. And then on the odd iterations, you scale the columns to match the column marginals. And so now you're going to adjust D1, but the key is that you're using the latest version of D0 as you're adjusting D1. And so IPF goes back and forth, adjusting D0, adjusting D1, and so on, until hopefully you converge at a solution. And what's known is that if the iterations converge, you do find a fitted matrix, D0 x D1, that matches both target marginals at the same time. So it matches both P and Q. And there's another very nice interpretation of this fitted matrix, which is that in addition to matching the target marginals, it otherwise remains as similar as possible to the initial matrix X in terms of minimizing KL divergence to X. And so with this intro, what we're really doing when we use IPF to infer the CBG POI networks, this is what we're really doing. So we take the original IPF with the row marginals P and the column marginals Q. Those very naturally serve as the hourly visitors from CBGs and the hourly visitors to POIs. So those are our marginals. And then the initial matrix now becomes the monthly network that was also given to us by SafeGraph. So if we apply IPF to infer hourly CBG POI networks, what we're really doing is we're learning a new fitted matrix that satisfies the hourly visitors, the data that we have on hourly visitors, but otherwise remains as similar as possible to the monthly network in terms of minimizing KL divergence to that monthly network. And since the methods are quite rich here, we actually wrote a whole second paper thinking about this IPF algorithm and what it means in the context of inferring these dynamic networks from their marginals, which I'll talk about briefly here. And this is work co-led with Fred Kohler and Jiaonan Xu, who published in ICML this year. So the first thing that we noticed in this work is that this problem that I just described with SafeGraph data, it's actually a more general network problem, which I would define as inferring a dynamic network from its time-varying marginals and its time-aggregated network. And this appears wherever it's easier to observe the outer parts of the network, so basically the totals of the network, but harder to observe the interior. And I'll give you two other examples. Beyond mobility, you might see this happening in transportation data. So for example, maybe you have a subway system. It might be easier to observe when people swipe into a subway station and when they swipe out of a subway station using the turnstile data, but it's harder to know the paths that people are taking from input stations to output stations. So that's somewhere where this problem would apply. Another example might be migration data, where it's easier to observe the flows into and out of regions, but harder to know the paths that people are taking between regions. And so in all of these cases, IPF could be a potential solution, and it's quite natural since it deals with these marginals. But IPF in the past has been mainly used for this matrix balancing problem, which is about trying to fit the marginals, but it hasn't been explicitly used to infer some underlying network that we assume to be a true network. And so that's really what this work was about. It was about asking, why is IPF a good idea here? And specifically, under what model of a network is IPF a reasonable estimator of the dynamic network from its marginals, so using the data that we're giving it. And so I'm going to go over the results quickly. We basically come up with a generative network model where IPF actually recovers the maximum likelihood estimates of the network's parameters. And so specifically this model, what we have in this model is first a time-varying network xt and a time-aggregated network x bar. And we assume xt is drawn from a Poisson distribution with a mean parameterized by x bar. And we have these scaling parameters that are scaling x bar, both the rows and the columns of x bar. And under our model, we assume you don't observe the time-varying network or the time-varying scaling parameters. But what you do get to observe is x bar, which is the time-aggregated network, and you also get to observe the time-varying marginals. So those are the row totals and the column totals of xt. And the main result is that under this model, IPF is actually going to recover these maximum likelihood estimates of specifically the scaling parameters. So the U and the V, it's figuring out what U and V is in every time step. And the basic intuition for our proof is that the log likelihood of our model is equivalent to the dual of the KL problem implied by IPF. And so what are some implications of this result? Well, first of all, we've answered our motivating question, which is, why is IPF a good idea here? And we've defined a model under which IPF is a reasonable estimator of a dynamic network from its marginals. And in addition, this model reveals some implicit assumptions that you make when you're using IPF for it to be justified. For example, assuming only time-varying row or column factors. The model also enables new analyses of IPF. So like I said before, IPF has mainly been used in context of trying to fit the marginals. And so it's usually evaluated in terms of how much distance there still is to the marginals, as opposed to what is your estimation error on the true network parameters. And you can also now quantify uncertainty as well as test model misspecification. And some bonus things for people who are interested in IPF, we also come up with an algorithm to enable IPF to converge on sparse real-world data. And we also do experiments in a setting where we do have the ground truth hourly networks. So this isn't the SafeGraph data, but using bike share data from New York City, we actually have the ground truth, and we're able to test how well IPF can get to estimating that ground truth. But for now, let's come back to the application. So we have this theoretical justification now. We're going to use IPF to infer hourly CBG POI networks. And we do this for 10 of the largest metropolitan areas in the US for the first wave of the pandemic, so from March to May 2020. And I talked a bunch about the theoretical properties of IPF, but one of the nice empirical properties is that it's very lightweight because all of these factors, the row factors and the column factors, they can be computed in parallel. So that means we're able to infer these large-scale networks with 500,000 POIs, 57,000 CBGs, and 5.4 billion hourly edges. And we actually released our networks in agreement with SafeGraph, and they've been downloaded by hundreds of researchers and used in various follow-on studies. Now we're going to incorporate our networks into an epidemiological model. The key is that we keep disease states for every census block group, and those disease states are a standard compartmental model, so susceptible, exposed, infectious, and removed, and we have one for every CBG. And by putting these things together, we can model the spread of COVID across CBG. And let me give you a toy example to explain how the model works. So let's assume there's only 2 CBGs for now, and only one person in CBG B is infectious. So if that infectious person and a susceptible person from CBG A show up at the same point of interest, maybe a grocery store, now there is some risk that the infectious person infects the susceptible person. And let's say, unfortunately, that happens. So now the susceptible person will become exposed, meaning they are infected, but not yet infectious. And after some time, they both go home, and the exposed person also transitions into infection. We also model a second type of transmission that happens in your home CBG, separate from POI visits. So that could be because you live in the same apartment or because you pass each other on the street in your neighborhood. And so let's say those 2 infections happen here as well. And so now you have 2 infected people in each CBG. And this was a toy example, but it shows you how an infection can spread from one CBG to multiple CBGs through these POI visits. Another thing I wanted to note is in our model, we're able to get POI-specific probabilities of infection, and that's using other data from SafeGraph, like the area in square feet of the POI and the median dwell time, which is how long people visit how long people stay when they visit. And there's also, of course, the number of infectious visitors, which is endogenous to the model, as well as mask-wearing data, which we're able to get at a daily granularity. And so altogether, our work can be described by this pipeline. You start off with the SafeGraph location data, you do your network inference, and then the hourly CBG POI networks go into the model along with a lot of other ingredients. And then we fit the model on reported case counts from the New York Times, and we fit the model, and then finally we're able to use the model for a variety of use cases, which I'll tell you about. And one thing I wanted to note is, as promised at the beginning, our model is able to be so simple because it takes in all of this real-world data. The model itself only has 3 free parameters, so literally 3 numbers, and we're still going to try to model the time-varying spread of the disease, even though the 3 parameters themselves are not time-varying. And despite how simple the model is, we are able to capture these complex case curves over time. And so, for example, here you can see the model can capture the linear trajectory in Chicago, but it can also capture harder curves, like in New York City, the cases go down, or in Philadelphia, the cases plateau. And certainly the fit isn't perfect, but again, our model only has 3 time-fixed parameters, and so the mobility networks are really bringing the power to the model to be able to capture these time-varying curves. And so we also conduct a series of robustness checks showing that it really is the networks themselves that are enabling the model to fit the curves. We compare our model to an aggregate mobility model. So the aggregate mobility model takes in the hourly total mobility, but no network. And so that basically means it's able to capture the massive drop in mobility in March when everyone started socially distancing. So it can capture changes over time, but it doesn't see where those visits are getting distributed to. So which CBGs are actually visiting which POIs. And we find that this network information on top of the hourly totals is quite important, and our model's RMSE is significantly lower. And we also test parameter identifiability. We simulate the spread with known parameters, and we show that our model fitting process is able to recover the true parameters. And we conducted a series of sensitivity analyses. At a high level, we find that they don't make a difference on our main results. So now we have this fitted model. What can we do with it? And so this is where it gets quite exciting. We can use it for a variety of use cases. The first type is called retrospective analysis. And that's taking advantage of the fact that the model realistically simulates who got infected where and when, down to the CBG, the POI, and the hour. And this allows you to test, for example, disparities in infection rates, seeing which CBGs are most at risk, as well as differences in riskiness of which POIs are the riskiest to visit. We can also do forward-facing experiments, and that's taking advantage of the fact that the model is very interpretable. So it takes in these interpretable inputs, like the mobility networks or the initial disease states. Now you can modify any of those inputs and run the model forward to see how predicted infections change. And so, for example, you can test fine-grained changes to mobility, or you could test vaccination strategies by changing the initial. So I'm going to show you two example use cases. First of all, we're going to test a partial reopening strategy where we reopen all POIs, but we cap visits to some percentage of its maximum occupancy. And when we evaluate a reopening strategy, we're going to look at two different objectives. On one hand, you might want to maximize visits after reopening, since visits serve as a proxy for businesses, for the economy, for consumer needs. But on the other hand, of course, you want to minimize infections. And so using our model, we can evaluate both of these things. And unsurprisingly, there is a trade-off between the two things. And so if you have more visits, that's going to lead to more disease spread and unfortunately more predicted infections. But the exciting result is we find that the curve is quite nonlinear, meaning a small reduction in visits can lead to a large reduction in infection. So for example, we see that if you use a 20% occupancy cap, you get a 40% reduction in visits, but an 80% reduction in new infections. And the reason this works is because, again, you're exploiting heterogeneity. You're exploiting the fact that most POIs are not getting to their maximum occupancy or even some percentage of it. So for all of those POIs, you can have business return as usual. And then only for the POIs that are hitting more their high density risky hours, you selectively reduce visits from those POIs in those hours. And so you get a lot of bang for your buck, essentially. The second use case I'll tell you about is disparities. And so at this point in the pandemic, this was late 2020, it was well known that there are large disparities in infection rates across communities, and lower income and minority neighborhoods were getting infected at higher rates. The question, though, was where are these disparities coming from? And what was quite remarkable was that when we built our model, we didn't tell our model the demographics of the CBGs. We didn't tell it which ones were lower income or which ones were more minority. But we found consistently that from the mobility networks alone, the models consistently predicted the disparities correctly. And so we saw that in all 10 metropolitan areas, lower income and less white CBGs were getting infected at higher rates under the model. And so the question is, how is the model able to predict these disparities from mobility networks alone? We look into the mobility networks and we found two mechanisms. So the first one is that lower income and less white CBGs had smaller reductions in mobility. And that could be because they're overrepresented in essential jobs or less able to work from home. So that's the first thing. The second thing, though, is it's not just how often you go out, but where you go. We found that lower income and less white CBGs, their residents tended to visit smaller and more crowded POIs with longer median dwell times. And on average, for example, one trip to the grocery store was 2 times riskier for someone from a lower income CBG compared to someone from a higher income CBG in Chicago. And so these findings suggest that mobility could be playing a substantial role in why we see these disparities in infection rates, which then guides how policymakers can address these disparities, thinking about mobility-based interventions as opposed to things, other types of. And so when we released this work, we were excited to see that it reached broad audiences. Like Ahmed mentioned earlier, we did receive coverage from over 650 news outlets. Equally importantly, we gained the attention of policymakers and deciding institutions. So for example, governments, US, Canada, Poland, and so on, the figure that you're seeing here is actually one of the figures from our paper remade in a Polish newspaper by the Office of the Prime Minister. We also cited in 2 US Supreme Court amicus briefs, and also by the CDC, the New York Times editorial board, and the US Joint Economic Committee. And so given this attention, though, we wanted to translate it into concrete decision support, real impact for policymakers as this pandemic was ongoing. And so to do that, we partnered with researchers from the University of Virginia, and they had been advising the Virginia Department of Health for about a year on pandemic policies. And they saw our Nature paper come out, and they reached out to us. And they were saying, this department is also looking for data-driven tools to help them with the next phase of the pandemic, the reopening phase of the pandemic. And so together, we partnered together to turn our model into a front-facing dashboard that the Virginia Department of Health could use to guide their reopening plans. And specifically, what this dashboard does is it allows them to put in a hypothetical mobility plan. And then under our model will predict what the predicted infections are for different Virginia regions under the hypothetical mobility plan compared to status quo. And creating this model and this dashboard required a bunch of extra steps. For example, fitting the model to Virginia and the new time period with various new features to the model, and then also building a computational infrastructure that enabled us to run the model quickly and at scale. And so for all of this work, it was actually awarded the Best Paper Award in KDD 2021 in the Applied Data Science track. So that's what I wanted to say about mobility networks. Let me talk briefly about a few other data sources. And so at a high level, we've looked a lot at mobility data, which I see as a good example of looking at what people are doing. So you can see where they're going, for example. And these are things they've already decided to do. But it's not quite enough to know what people are doing. In order to understand behavior more holistically, you also need to understand how did they get there? How did they choose to take that action? And to do that, you need to understand better what are they thinking? What are their motivations? What are their beliefs? And to get that kind of information, we rely on other types of data sources, usually more user-generated data like search logs or speeches or social media. And I don't have time to talk about all these papers today, but I'll briefly note, we have work that's looking at search logs to analyze vaccine uptake and hesitancy from search logs. We've also measured attitudes towards immigrants from 140 years of US political speeches. And in other work, I've looked at Twitter and news articles, even Rate My Professor reviews to understand things like gender biases. And so these sort of user-generated unstructured texts are a really rich source of data to understand how are people thinking and feeling, which is really important, especially in these crises, like pandemic crises. And finally, of course, using these sort of data sources comes with a lot of necessary discussion because they are still imperfect. So for example, mobility data doesn't cover all populations. Search logs, which we also use, don't cover all types of individuals or types of vaccine seeking. And you still, of course, need to balance social benefits and privacy and use this data very carefully and in aggregated ways. The models are themselves imperfect. So for example, the SEIR model makes these simplifying assumptions a trade-off for keeping the model quite simple. But still, we are able to estimate behavior at finer granularities and derive these really important public health insights by combining these novel data sources with machine learning techniques. So in the mobility data, we are able to infer these hourly mobility networks and combine it with an SEIR model to get accurate fits of real COVID cases. This then allows us to study who got infected where and when, which informs reopening and disparities. And I didn't get to talk about search logs and vaccines as much today, but we built this graph neural network, so a deep learning architecture to infer from search logs when someone is trying to get the COVID vaccine. And we're able to validate it with strong performance in all 50 states and strong correlations with CDC rates released at the state and county level. And this enables us to do fine-grained, real-time monitoring of vaccine rates and concerns. So one tidbit I'll share with you is we actually find that our search signals precede the CDC data by 1 to 2 weeks. So the time that it takes for someone to look up, like, where can I get a COVID vaccine, to the time for them to get vaccinated and for that vaccine to get reported in the CDC data. Now you can get ahead of that delay and preempt vaccine demand and vaccinations a lot better. So now with the remaining time, I'm going to switch gears and talk a little bit about the simulation side of things, starting with generating social networks. And so this is relatively recent work, co-led with Alicia Hostrovich at Stanford. So now we're thinking about generation. And why do we want to generate social networks? Well, coming back to epidemic modeling, that's already a good example. Maybe instead of trying to infer the contact network from novel data sources, we could try to generate the contact network instead. And so try to simulate who is likely to come into contact with whom. You might also want to generate social networks for social simulations, or maybe if you're prototyping a new social media platform, you want to understand who might be friends with whom in a realistic way. And so prior work on generating social networks, one common approach is using stylized network models like random graph models or preferential attachment. And these models are quite useful, but they often aren't that realistic. On the other side, you can do deep learning. And so like you can use a graph neural network. And the way this usually works is you give it a large number of observed networks. And from those observations, it learns how to generate the next network. So these are quite realistic, but they're no longer zero shot, meaning they need a large number of data in order to train the model. And so here in this work, we see large language models as an exciting new opportunity because first of all, they're flexible, meaning you can define any agent in the network using natural language, and you can use whatever features you want for that agent. You could even use different features for different agents. It's zero shot because the large language models have already been pre-trained on so much internet data and so much things online that you might not need additional training data to generate a social network now. And then the key question is, do they generate realistic social networks or not? And that's really the driving question of this work. Can LLMs generate realistic social networks? So on one hand, LLMs have ingested a lot of social knowledge during pre-training, and prior work has demonstrated abilities to realistically simulate human responses and interactions. On the other hand, though, it's not clear how LLM's language abilities will generalize to these discrete objects like graphs, and in fact, prior work has shown that LLMs struggle with reasoning over graphs. LLMs can also sometimes show demographic or political biases. And this can be a particular issue for social networks because demographics play such a large role in how social networks form. In particular, there's this property called homophily that you might have heard of before. And it's basically saying birds of a feather flock together. And it says people with similar traits or similar demographics tend to end up being friends. And so to test this question, we come up with 3 network prompting methods. The first one is called global, where we make the entire network at once. And so we give it a list of all of the personas in the network, and we have it generate all the edges in the network. The second approach is called local. So we assign one persona at a time without network information. And so we assign it one persona, we give it its identity, and then we give it the list of the other personas to choose friends from. And then the third method, sequential, is similar to local because you're assigning one persona at a time, but in addition to providing descriptions of the other personas, you're also giving information of the network as it's been constructed so far, depending on the earlier personas that you already queried. So you can give the IDs of the people who are already friends with each other. And to test these methods, here's our experimental setup. We sample the personas from the US population distribution. We generate 30 networks for each method, and we evaluate various structural properties of the networks, for example, their density, their degree distribution, and so on. And then to evaluate homophily, so remember that is the trait, like people with common traits are likelier to be friends. We compute that as the proportion of the observed same group edges. The same group would be something like same gender, so women and women being friends with each other. The proportion of same group edges divided by the expected proportion of same group edges based on how many people from each group are in the network. And then finally, we compare our generated network to 8 real-world social networks. So let me go over some high-level results. First of all, we find local and sequential generate more realistic networks than global. So remember, global is when you generate the entire network at once, whereas local and sequential, you assign one persona at a time. And so this is quite interesting because global actually has strictly more information than local and sequential, but local and sequential are closer to how people in the real world form friendships. So I think most people, when they enter a social network, they don't have this global view of who is friends with whom, but they only have a very local view of who they happen to bump into and who they want to become friends with. And even with only that very local view, you still see global characteristics emerge. And so, for example, density or clustering, you see these global characteristics emerge even as people are making local decisions. And we see that to be true for LLMs as well. Another finding that we find is when we compare local versus sequential, we can evaluate specifically what is the value of providing network information as you're making these individual persona choices. And the main difference between the two is we see that sequential can capture the long tail degree distribution in a way that local can't. And so it's interesting to see that sequential can actually simultaneously match a large number of graph characteristics in a way that classical network models can't simultaneously match. And so this is promising that perhaps sequential could be, and LLMs more generally, can serve as a good zero-shot method for generating structurally realistic social networks. But before we get too excited, let's talk about homophily as well. And so remember, homophily is, we're measuring it here as the ratio of same group edges observed to expected same group edges. And so a ratio above 1 means that there's homophily. And what you can see here is for all of these demographic variables, there's clearly homophily in the generated social networks by the LLMs. In particular, we find that the LLM consistently pays the most attention to political homophily, especially the local method and the sequential method. So what this graph means is local is showing that same party edges are appearing more than 80% more frequently compared to expected, and sequential is having them appear around 68% more frequently than expected. And so they're putting a lot of attention on this. And we also find that the attention on political homophily, it holds even if you do various changes to your setup. So we tried shuffling the demographics to break correlations between demographics, and still political homophily is the highest. We also try adding interests to the persona description. So not just demographics, but also interests, but we still see that political homophily is the highest. And it's not only that LLMs pay the most attention to political homophily, they pay so much attention that they actually overestimate political homophily compared to real world measures of homophily. So we compare it to offline networks as well as online networks. Offline would be like family or people you trust. Online, we look at Twitter. And in all of these cases, no matter how you're measuring homophily, we see significantly more political homophily in the LLMs compared to the real world networks. We also conduct some additional results. So we experiment with 6 different models, and we find that consistently over all 6 models, they overestimate political homophily. And the most extreme is actually GPT-4o and Llama 3.17 billion, where we actually see complete segregation. So that basically means these models refuse to make Democrats and Republicans friends, and the network fractures into 2 disconnected components, one for Democrats and one for Republicans. And so this sort of overestimation, it has some implications, because if you now want to take these synthetic networks and do something like run an epidemiological model over it or run some sort of polarization model over it, you would end up overestimating polarization because you're overestimating this homophily. And so there are important implications that mean we shouldn't be using LLMs yet for these kinds of tasks, at least if you'll generate your synthetic networks this way. We also do various other things, like prompting the LLMs to provide a reason for selecting friends, evaluating bias in LLM-generated interests, and different robustness checks. For the sake of time, I'm going to skip my other ongoing work on simulation. I'll just say briefly, we're doing some work on simulating public opinions as well. So that's where you give it some public opinions question, and you try to match the LLM's answer distribution to the real world answer distribution based on a US representative survey, like the Pew survey. And we're working on developing fine-tuning techniques to make this process more faithful to the real human distributions. And I'm also doing some work now at Microsoft of simulating users to evaluate AI systems. And there, the idea is that the way that we evaluate right now doesn't really capture how users actually use generative AI systems. So if you look at, for example, standard question answering benchmarks, they tend to be very static instead of interactive. It's not a conversation with the user. And there's these other differences, like the format is often multiple choice, the topic distribution doesn't match the real world, and prompts don't match real user styles of speaking. And so in our work, what we're trying to do is to scale this sort of evaluation so you can do it with user in the loop. Well, it would be very hard to get these infinite copies of real users for evaluation. So instead, we're trying to build simulations of users so that we can do more realistic, scalable generative AI evaluation. And so finally, I'm going to end on this slide of saying, I talked about simulation. This is mostly more in the developmental context. It's not quite applied yet, but there are a lot of applications of simulation in public health. So I talked about generating social networks. You can definitely use that as proxies for contact networks to model spread of disease, but you could also use it to, for example, model information ecosystems on social media to understand who is seeing what information, or to model social influence in health behaviors. So in public health, we know that a lot of health behaviors depend also on the local network that you're part of. So if a lot of people are vaccinating or a lot of people are masking near you, you might feel more obligated to do it as well, or more encouraged to. With the simulating public opinions work, you can naturally extend that to try to simulate responses to public health policies and messaging, and maybe use them in tandem with public health surveys of real participants to scale those experiments. And then finally, user simulators for this AI evaluation. There's already these very cool generative AI health systems that are being built like chatbots for health. And so can we actually simulate how patients might use these chatbots to get better evaluations of those generative AI systems in health? So I think it's a really exciting area right now, this intersection of simulating humans and public health. And I'd love to hear any ideas that you have. With that, I'm going to end here and would love to take questions. Thank you.
Yeah, so maybe I can start with a question on the second part.
Yeah.
So just my impression from the literature on like random graphs and or like the older like non-behavior focusing literature on how networks emerge, it seems like the meeting process is kind of what gives rise to structure. So like in your simulations, like it's like if you are meeting friends of friends more than and you have this homophilic tendencies, then you will end up with like preferential attachment, like something like this. Are you able to simulate like a wider range of structures by incorporating behavior, or is the modeling of user behavior more relevant for simulating opinion dynamics on an already existing networks? Where like you actually want to simulate how people are thinking and processing information and passing information, like something that would be hard to simulate with these very simplistic probabilistic models.
Yeah. So I think that's cool. I think it would be possible. Like right now, the way that we're using our LLMs feels a little bit contrived. Like we just take our LLM and we like give it a list of everybody in the network and we say, who do you want to be friends with? So it's sort of a first pass of the naive way that you might do this, and we do see promising results already. But I think a cool next direction, which maybe speaks to what you're suggesting here, is to make it more behavior-centric, more person-centric. And so you could actually instantiate each LLM as its individual agent and sort of drop it into a simulation system. This is similar to what June Park at Stanford has been doing around generative agents. And you have them interact in the simulation space where you just allow them to organically talk to each other. And so instead of having them like asking them like, who do you want to be friends with? Instead, you let that organically evolve over the process of your simulation. So maybe at each time step, you allow it someone, you can talk to someone. And depending on how much they enjoy that conversation, on the next time step, you say, do you want to keep talking to each other, or do you want to find a new person to talk to? And you do that over some number of time steps, and maybe you'll converge at a network eventually. And I think it would be really interesting to evaluate in that more organic system. Do you see more complex networks emerge, and do you still see that you correctly match the real network properties?
Yeah. I think we can take questions in the room.
Yeah, so when you're building these models for public health or behavior, what type of data have you interacted with that has been the most impactful? And then what type of data do you wish you have, but you don't have access to for some reason or another? That would both sides of the coin.
I think there's I think two types of data that I interact with quite frequently. There is the data that we use to estimate the behaviors. And so that's often like these novel data sources. So mobility data and search logs, I think, are really powerful in those settings. So mobility data is powerful because it's like passively collected and we have really frequent signals of it, and it's really good penetration. Like we can see a lot of mobility patterns. And I think towards public health, especially infectious diseases, mobility patterns are just so relevant, both in terms of knowing who is coming into contact with whom, but also if you want to measure like compliance or efficacy of public health interventions. Like we have some work I didn't talk about today, looking at what happens when people actually have lockdowns in their counties, but maybe their neighbors aren't locked down. We could actually see, using mobility data, spillover effects of people leaving their own county to go to the neighboring counties so they can still, for example, eat out at restaurants. So mobility data is super impactful because you can track these behaviors. I think search logs are really valuable, which I didn't get to talk about as much today because they can capture the process through which people get to the behavior that they decide on eventually. So you can see, for the same person, you can see so much information. Like you can see what news they're consuming. You can see what queries they're issuing, which gets you a sense of what are their concerns. And then you can actually see some outcomes in a way. Like you can see if they're trying to get the vaccine, things like COVID vaccine near me, or where can I get a COVID vaccine? And so you can get this, dynamic process from when they start researching the thing to when they have an outcome, and you can see after past that as well. And some health researchers have used search logs in really effective ways. Like one of my collaborators looked at it to understand pregnancy. So you could see, like, if somebody looked up like 10 months pregnant, then you can also look in the window around that to look at, oh, well, was she looking up at 7 months pregnant or 8 months pregnant, and look at the intersection of, this grounded experience that you get from one of the queries, along with all of this information queries and the other types of concerns that she or he might have. So yeah, search logs and mobility data are really powerful. And then on the other side, I think you need to have some sort of like health data or outcome data to validate what you're doing. And so, for example, we've heavily utilized government public, like data from public health departments. So for example, we've seen CDC data for vaccination rates, or we were using daily cases that were getting reported by public health departments. So to actually validate whether these inferences that you're making over novel data sources, whether they mean anything. So I think you need both sets of data in order to do this kind of work.
Other questions in the room?
I guess I'm sort of wondering, how does this type of work get translated into public policy? So you gave the example of you partnered with University of Virginia, but I guess like broadly speaking, like how does this work actually translate to public policy? Because I'm thinking, like for medical devices, there's like the FDA, for example. Is there an equivalent for like this kind of work? And yeah, I'm just curious your general thoughts on that. Like how does this actually translate?
Yeah, it's a great question. I mean, and this is something we're always exploring as well. I think in our experience, we are working with public health departments, and so we can help them come up with more data-driven ways of making decisions. So for example, with the Virginia Department of Health, they wanted more data-driven ways of understanding what reopening policy should they implement. And so using our tool, they were able to see that, reopening different places, it's not like all POIs are created equal. So certain types of reopening are going to lead to more infections compared to others. And so then they could come up with more tailored plans that actually exploited these differences and risks across POIs. So that was a reopening dashboard. We also continued working with them on vaccine distribution. And I think this might be an even clearer example of where this kind of data and research is useful. So they had a problem of, they had a bunch of mobile vaccine sites. So basically trucks that were carrying the Johnson & Johnson vaccine, and they had a limited budget of these. And so they were trying to understand, where should I place these sites physically? Where should I place them in Virginia and within certain counties? And so then they reached out to us because they knew we had been doing all this work on mobility data, and they wanted to use mobility data as a proxy to guide where should we place these vaccine sites. For example, maybe you could place it right next to a grocery store that a lot of people are already going to for maximum convenience. And so you place it near somewhere where there's already a lot of visits. And so we actually did deliver weekly vaccine site recommendations to them. And we were able to show, and we have a paper on this that I can point you to, we were able to show that our recommended sites ended up having more vaccines administered compared to sites that were far away from places that we recommended. And so there, the mobility data can really guide in this data-driven way, how do we make public health decisions.
A couple of questions online. I think we can combine them. So like there's a question about how social determinants of health interact with the model. And it seemed like disparities emerged from your model as a result of mobility patterns being correlated with demographics, but are there other behavioral aspects that are also demographically
Yeah.
different could interact with your model. There's another question also about vaccines and like other I guess vaccines and other non-pharmaceutical interventions. It seems like your model focuses on mobility to fit the epidemiological model, but I wonder if it takes into account other things
Okay,
that
yeah.
structure it as well.
I can answer the social determinants one first. Yeah, so the goal of our work was to really keep it light-handed and focused on mobility. Like I think one of the surprising results is with this very simple epidemiological model and just mobility networks, we can fit these case curves and we can see these disparities arise just from the mobility networks. So we didn't try incorporating additional social determinants. The point was to show mobility networks themselves already show these disparities. But I think the mobility networks encode a lot of information. So we already saw two mechanisms, which is that these groups were not able to reduce their mobility as much, and even conditioned on the type of place they were going to, they tended to go to places that were more crowded, with more visitors, and with longer wait times. But this is only based on the mobility networks. I think one thing that I didn't mention during this talk that has to do with social determinants of health and also has a lot to do with networks is homophily. And so what we mean by the reason why homophily matters here is it's not only that lower income people are going to higher risk POIs, but that other lower income people are also going to those POIs. And if those populations are already at higher risk, then there's this sort of self-exacerbating cycle where you are also mixing with other people who are already more at risk. And so then because it's an infectious disease, their risk could spill over to you. And so there's this sort of cyclical effect, because you have similar groups appearing in similar places and dissimilar groups not appearing in the same places. You end up having these additional risks because the people you're mixing with often are also higher risk. So I think that sort of cyclical effect is quite important to model, and networks is a really good way of capturing it.
Yeah.
The other question was about vaccines. Sorry, could you repeat?
Oh yeah. I think it's the question is, have you considered now that like there are other forms of both pharmaceutical and non-pharmaceutical
Right.
interventions that would not only affect like the way mobility influences the spread of the disease, but also like how valid the model is over time, like after vaccine deployment versus before, like the mobility would have a different impact. So have you incorporated?
Yeah. So this is quite important because so when we fit our model on the first wave, we found that mobility was very predictive. And even up until like late 2020 and going into early 2021, when we deployed the dashboard for the Virginia Department of Health, we are still finding good results with mobility. But over time, especially after vaccines were introduced, I think mobility became less of a good predictor for case rates. And we see this in other work as well. And so I think there's a number of published papers showing that the association between mobility rates and COVID rates, that association got weaker over time. And so we didn't try doing this in later phases of the model after vaccine rates were developed, but I think it would be important to incorporate those additional factors into the model. So that's one nice thing about it with the disease states. I think there's a pretty natural way of modeling vaccine rates. So you could, in the extremes, you could put them all in the removed state, or you could add an extra state called vaccinated. And you say for the vaccinated people, this is their level of susceptibility, and this is how quickly they will move into, say, the susceptible state after some time if the vaccine wears off or you have some new variant.
Other questions? Yeah, Andrew.
So this is all really, especially the portions when you talking about the simulating behaviors and future predicting behaviors of populations.
Yeah.
You've been talking a lot about on like a public health level. I'm wondering if you thought about how the model may react to something on like a population health level, which can sometimes be more specific and more granular and may not always fit like public health kind of like trajectories of like health behaviors.
Yeah.
If you thought about that, or like if you know how it might react.
That's interesting. Could you talk about a little bit more about like where you think it might differ?
Yeah, so I guess in my own experience, in population health, like we would do a lot interventions in a population health setting can be actually any intervention can be very expensive, and so you always try to do like some like background research to see like how patients would react to like pop-up clinics or like certain types of like vaccine deployments for like very specific populations, like elderly patients in like very specific like zip code areas. But then oftentimes even if we're doing it oftentimes like from data that we're getting from like at a public health level, talking to like community leaders and papers that look at things kind of like at a more globalized scale. But then the behaviors of like these individual populations, because they're like much smaller, they don't always react or behave in the same ways that you think that they will. So sometimes turnouts tend to be a lot lower than you think they will be, or like maybe it's just like the way that we message things don't resonate with like very specific groups of populations.
Yeah, that's a great point. Yeah, and I think that distinction makes it really clear. Thank you for explaining. Yeah, I think it's really important, and maybe one of the opportunities with these sort of simulation-based technologies is we can capture these smaller populations that sometimes go unseen, maybe because they're harder to reach, or just because they're a smaller part of the overpopulation, they get overall population, they get overseen. And so I think ideally what you can do is get to know these communities better, but maybe augment that process with simulations of what they might do. And so these LLMs are ways to capture more diverse voices. Instead of just always looking at the average person in your population, you can actually condition them, tell them to be like a particular person from a particular community. And if you have rich data to train them on so that they can actually better understand what that community looks like, they might be a really good way for you to hear voices from that community more, instead of always just looking at the sort of modal person in your population. But of course, that work needs to be done with care. I think, as we've shown with the final work on political biases, even for these very large groups like Democrats and Republicans, LLMs do exhibit some biases. And as you get to smaller populations, often marginalized populations, they might show similar biases or stereotypes about them, which is why I think having rich qualitative and quantitative data on these communities to teach the LLMs would be a good first step before you start trying to use them.
Yeah, I had a question about how your work got taken up by the news outlets and policymakers, specifically just looking at, say, limiting the maximum occupancy of a POI, right? Has a very different effect in a food desert in a small corner store than it does for, say, a large supermarket somewhere else. And so thinking about like beyond sort of maximum occupancy, what were some of the more creative things that people did that didn't individualize public health outcomes onto individual decisions, where I can imagine people standing in very long lines because the maximum occupancy in a corner store is like 5.
Yeah, certainly I think, and something that we have in our paper that I didn't get to talk about today is, even once you do these tailored reopening plans, the impacts of these plans will be felt disparately across different populations. And so, for example, we showed that lower income communities and minority communities, when they go to the grocery store, it tends to be these grocery stores that are more crowded, that do have longer wait times. And so then if you are disproportionately reducing visits from the more crowded places, that is going to disproportionately hit these already marginalized communities. So I think you need to think, it is nice to know that you can have these tailored results where you get a lot of bang for your buck, but when you actually go out and implement it, I think you should think about what are the consequences on these different communities and who is actually getting most affected by these policies. And so in addition to reducing maximum occupancy caps, you could try to explore other things as well. Like if you know those are highest risk, maybe you can introduce like these sort of barriers around maybe cashiers, or you can introduce more takeout opportunities or more deliveries. Like think about ways that mobility can reduce disparities. I think we were interested in seeing that mobility could be part of what's causing these disparities, which means that it's not just things like pre-existing health conditions or access to healthcare that result in these health disparities, but also these more short-term things that maybe you can make policy around. So I think the solution for each community differs, but I think knowing that mobility could be playing a large role helps you, at least gives you a guiding point for how you can then address it within your community.
Yeah. Other questions? I think we can end it here. Thank you so much, Serena, again.
Yeah, thank you for the great questions. A lot of fun.
Looking forward to having you in Berkeley soon.
Yeah, likewise. All right, I'll see you. Bye.